Morning, everyone. Hope everyone had a good night last night. Hope everyone's positive cash flow, not negative cash flow. So, as Sherry talked about, the EDBA is an organization that's been around for several years, and we are one of the co-sponsors, of this talk, along with Rick Bicata, who's been along a lot longer with his EM abstracts. And why did EDBA come into existence? Well, back a long time ago, no one was interested in ED operations, and there was no data, and there's an opportunity to do something with this. And like everything else in emergency medicine, it started with an idea and one person, and ironically enough, that person was Bruce Janiak, and he was one of the founders of EDBA, and he has a story to tell about how the organization started.
When I started at the Toledo Hospital as chairman in 1974, and I was just contemplating that. This is since residency, my 44th year of emergency medicine practice, and I'm not burned out yet, so I must be kind of weird. Anyhow, one of my colleagues was Dr. Mike Irvin, who was chairman at Miami Valley Hospital in Dayton. And we just had a conversation and said, why don't we try to get together with our hospitals? And one of the first ones was Akron. I remember Providence Hospital in Cincinnati and several more, Hennepin County in Minneapolis. Got together and discussed the concept of getting data and sharing best practices with all players in the emergency department. So it would include the nurses and the administrators. A little harder to get the administrators involved initially, but we started with just our 2 hospitals, and within a year we had several more. And of course now you know we have over 1,000. So it's been kind of a feeling of giving birth to this fantastic creature now that is educating you and educating me and providing incredibly valuable information, which I believe we have the largest valid database for emergency medicine operations in the country. And if you can understand that data is power, you can see why the feds are interested in things that we do, at least on and off. One little anecdote about how we had our first success, which was not data, by the way. But in Ohio, the Blues wanted to demand that all asthmatic patients in emergency medicine have a pre- and post-treatment peak flow measurement. And I thought that was nice, except that the compliance, and compliance is a word that makes me insane, compliance was geared to hospital reimbursement from the Blues. And I couldn't find any real scientific data that said that was valuable. I tracked down some information. Anyhow, it ended up with all the then members of the Benchmarking Alliance meeting with the Blues in Cincinnati, and all of a sudden this regulation that was going to cut money from all the hospitals in the state was rescinded. That kind of set off a light in my head about how it is possible to fight the bureaucracy, and it is possible to gather great data, and it is possible to convince people that they might be on the wrong track. I could go on with lots of other stories, but we're not going to be here all morning listening to that. I wanted to welcome you to this meeting and thank you for coming. Please consider joining us if your hospitals are not already part of this organization. The more data we have, the better the data will be, and the better you can utilize that to manage your department. Where else in the world can you go and type at 3 o'clock in the morning, you guys tell me how many x-ray techs you have on at 3 in the morning for a 50,000 visit department. And in an hour, you have like 10 answers from 10 different places in the country, and within 3 days, you have 30 answers. That's the power of this alliance.
Thank you. So how many people in the room are members of EDBA? Thank you. We appreciate it. You're going to hear in a few minutes from Jim some of the data we have. Let me just show you some of the things that we've done. Since 2004, we've been collecting data across the country and able to compare like-minded hospitals with other hospitals, and we're able to compare each individual hospital over time and help you with that. And that's been tremendously important because as directors, I'm sure that you all get calls from the C-suite, hey, how come you're not performing like so-and-so? Okay? And it really helps to have the data to say, well, we're not like so-and-so, we're a bigger hospital, we're a teaching hospital, we have all the confounders that may affect operations. And with the database with 30 million visits, it's roughly 20% of the US population, a very representative sample size. And there's just a graphic depiction of where our members are. And the board is here. So if I can have my board members stand up. So we have Deb Ritchie, Steve Davidson, Sherry Welch, Jim Augustine, John Lyman in the back, and Charlie Reese is not here. And then we took Ron's advice last year and outsourced our management services, and that's with the ADEPT group out of Denver. Nicole Singleton in the back, you may have met yesterday. She was handing out drink tickets. That's where our management services are, so thank you. That's the board members. Please talk to the board members as it goes along. And one of the things we've done is we've published some of our data. The first benchmarking summit was in 2006, where we first did some of the definitions that everyone uses. The second was in 2010 in Salt Lake, where we talked about any changes since the previous time. And again, this was published in Academic Emergency Medicine. And then you may recognize the carpeting on this one. The last benchmarking summit was 2 years ago. It was about 3 rows over in a meeting room over there. And we talked about some of the changes that have occurred over time. And it may not surprise, this was published as well. This came out last May. And the interesting thing that we came up with was, how do we define decision to admit time, which was one of the CMS markers. And with the 40 people in the room, we had 40 different definitions. Everyone used a different definition. And the light bulb went on for CMS and said, you know, look, we can't define this. So we changed the definition, and CMS is going to incorporate that. So we work with other organizations. Jim talked to you about working with the CDC. We also work with the academic chairs, academic administrators. We work with ASAP, EDPMA, all the organizations. And our goal is to take all these data and to publish it and to get people interested in operations, because if we know our operations, if we can compare ourselves and benchmark, then we can affect it to benefit the patient and benefit the practice. So I encourage all of you to join and participate, and you're going to hear why from Jim in a minute with all the data. So thank you. Good morning.